It is just a huge honor for me today to be podcast interviewing Dr. Hilt Tatum, who is widely regarded as one of the world's most skilled dental implant surgeons and is unmatched in his surgical and conceptual talent. For over 40 years, he has been most gracious in giving his time and knowledge to advancing the discipline of implant dentistry to the dental profession. The lives of many patients and dentists have been enriched as a result of Dr. Tatum's innovative thinking, research, and implant techniques that he developed. In 1955, while a student at Emory Dental School, he attended the first program on dental implants to be given in a dental school. Throughout his career, Dr. Tatum's goal has been to bring the compromised dental patient back to normal comfort, function, and aesthetic dental health. He graduated from Emory University Dental School in 1957. In 1969, he began the bone expansion concept for the placement of implants. In 1970, he had introduced autogenous bone grafting techniques into oral implantology. In 1974, he developed the sinus lift operation and began to perform the inferior alveolar nerve lateralization technique. In 1975, he developed the sinus graft operation. 1978, designed sinus grafting and bone expansion instruments. 1979, designed the first two-stage titanium root form system in the USA and was granted FDA marketing approval in 1981. In 1982, he introduced the vascularized osteotomy technique with interpositional bone grafting. He's presented over 2,000 professional presentations worldwide. In 2003, Dr. Tatum was awarded the Chevalier of the French Legion of Honor by French President Jacques Chirac in recognition of his contributions to the healing sciences. My God, it is an honor and a privilege to be talking to you today. How are you doing?
Oh, well, I'm just wonderful. I'm amazed I'm here at my age. I never thought I would be alive at this age, but I'm so fortunate.
Well, how old are you now?
I'm 83, Howard.
83. Well, you look fantastic. I mean, you look just marvelous, and I love the room you're sitting in. It looks like you're sitting in Chirac's house.
Well, it's a lovely place. It's the walls were built in the 1500s. The chapel and guest house in the 1500s. This home was rebuilt in the 1700s. So there's much history in our area here. Great history.
Yeah, that is the amazing.
Lived less than a half mile from our home here as a child. William the Conqueror, who conquered England in 1066. Joan of Arc spent her last night alive a half mile from where we live. Monet's home is 16 or 17 miles up the river from us. Richard the Lionheart's castle is about 7 miles up the river from us. So there's much history right around us here. It's a lovely place to live.
So what made you go from being born in Alabama, practicing forever in St. Petersburg, all the way to France?
Well, Howard, I came here by accident. I fell off of a horse and had a serious injury. And my wife is French, and she had a home here. And so I came here trying to recover from the injury, thinking I'd retired. Had a couple of heart attacks and was certain I'd retired, but then survived it and am still here and still somewhat functional.
Fantastic. Well, what are your thoughts about the current, I mean, you were in oral implantology at the very beginning and contributed many of the major techniques we use today. How do you view the world of oral implantology today?
Well, it's a real paradox. I am literally one of the antiques that's still alive from the early periods. I'm not from the very earliest period, but right after that, in the 50s, I was introduced to the field. The earliest, I think it started in U.S. in 48, but I think today is implant education is a tragedy. I think that it's largely commercially controlled. In the teaching and the the talks I give to the students I work with, I liken the present field of implantology like the world was flat in 1491. And I think that what we have learned and what we and others are able to do is like the world is round of 1493 and 1494. It's a totally different dimension from what is traditionally thought of as conventional implantology today. It's so mechanical. There's so little skill required to do implantology. If you buy a kit and take a weekend course, and you can drill holes in bone and put screws in it. My whole concept is that I want to take a patient at any stage of dental disease, atrophy, or trauma, and have the potential to restore them to normal contour, comfort, function, aesthetics, and health. That's a big mouthful. I made that slide first in 1977 as being the goal of modern implantology. I feel like my life has pretty well been like a carousel. My learning has been like a carousel that I've been on. Entered the carousel back in the 50s and have been on it around. When I left the U.S., I think I was about 3/4 of the way around my journey. But fortunately, the accident I had incapacitated me for a period of nearly 2 years, year and a half anyway. And during that time, I was alive and I could function, but I couldn't do anything physical. And we live here in the same valley, right? The river's out less than 1/4 of a mile in front of our house. And we can't have a wine cellar because you get water about 4 feet down. But we live on the edge of the valley and have a cave that goes into the hillside, which is a wine cellar. It's been there, I guess, for nearly 1,000 years. So, no, it's been there probably 700-800 years. And I got an old furniture crate from a furniture store and put a top on it, put an umbrella over it to keep the water from dropping on my head. And for a year, I sat there and made instruments. It occupied me. I ran an electric cord in it, put some lathes and some dental equipment, and I made things to occupy myself, not knowing that the things that I made were going to totally explode my knowledge and my ability to do things better than I'd ever been able to do before. So that's one of the greatest gifts I've had, was not only the gift of surviving, but the gift of being able to create things that allowed me to do things better than I ever knew before or I ever dreamed was possible. And it has allowed me to complete this circle on the carousel to come to the point that I am right now, that I feel like, with the rarest of exceptions, that it's possible for us to complete that goal that we had of taking almost any patient and bringing them back to normal contour, comfort, function, aesthetics, and health. And by that, I mean rebuilding the bone to its normal dimension, putting implants within the areas that roots occupied, rebuilding the soft tissue to create gingiva in the correct places, and then doing restorative dentistry that simulates nature. And that's my dream, and now that's what is within our capability. So it's rather exciting to be able to live long enough to achieve your dream.
So talk about your website, tatumsurgical.com. Tatumsurgical.com. What are you What are you excited about on these instruments and implants that you have?
But that's the website of the company of the implants that I created, and I actually have very little to do with that website. I still teach. I'm the director, co-director of the Maxi course in Puerto Rico. I'll be leaving day after tomorrow if the storm doesn't block it to go to Puerto Rico, and it's supposed to be right at Puerto Rico on Wednesday when I get there. Help with in a number of the other Maxi courses. So my main endeavor is through these educational outlets. Not I'd have almost no role in the commercialized end of selling implants. I designed them and developed them, and certainly am interested in it, but I know very little about that website because that's not something I could really talk with you about much.
We just had 6,000 children graduate from dental school 3 months ago, and another 6,000 just started dental school this week in the United States. A lot of them come out of dental school and say, we never placed a single implant. What advice would you give to a young 25-year-old dentist how she could learn how to be an implantologist like you?
Well, I think education's a tragedy. As you say, most dentists graduate from dental school with very little knowledge or introduction to implantology. If they have introduction, it's very rudimentary and very basic. But I think that's expanding and becoming better. But in my opinion, implantology now is the most complex field of implant dentistry. Implant dentistry is the most complex field of dentistry today, and we have won the legal battle of being able to announce, in most cases, and soon over the whole country, announce the specialty of implant dentistry with those people who have been credentialed through the American Board. But we are now challenged with developing the education to complement that so that we have the widespread education, not only for the general dentist and the other specialty areas to do implants, but to train people to be the teachers and to treat any patient with complex treatment for those patients who need and desire it. So that's our real challenge today, is to develop the education to enhance and to train teachers to teach the young dentist and the practicing dentist into a more complete area of competency in the field. And that's our challenge. And I have thought this for a long, long time, and I have had some part in the development of the legal challenge to create the rights of dentists with comprehensive education and experience to announce their competency through specialty recognition. And as you know, we've achieved that now. Now we've got to develop the education on a widespread basis in the dental schools and outside. I have a whole plan of education that I think is appropriate and I hope will be implemented within the American Academy of Implant Dentistry as the driving force to develop this education, and I hope that'll happen.
So how is the American Academy of Implant Dentistry Maxi courses, how are they coming along now?
Well, they're expanding, but the Maxi courses are just an introductory level of education. What we've got to do now, Howard, is we've got to develop multiple graduate programs, university and hospital-based, that will offer 3 and 4 year and more graduate education. And we've got to develop the teachers. We have so few people in America with the capability to do the most complex procedures. There's so much commercial education and there's so little sincere, deep developmental education within the field. So much of it is controlled to sell this product or that product, or promote this or promote that, as you, I'm sure, are aware. But I hope and I dream and hope that the American Academy will use its resources now and its leadership to develop this in-depth graduate education that we need for the most serious people and for the introductory people, so that we raise the whole level and take it from this flat world concept into the world is round concept that I know is possible, and where a person fits into it will depend on their desires and their capability and their training. It's a big dream, as you perhaps can see.
Are there any textbooks that you recommend for reading?
It hasn't been written yet.
Are you writing it right now?
Oh, I wrote a book in the early 80s, but I'm so glad I didn't finish it and have it published, because it was incomplete. And there's not a book covering the things that are possible, but perhaps there will be. But I'm sure that the things that have been learned are going to survive and be taught, probably not so much in book form as through digital form, because with digital, you can, as you know, what we're doing right now, you can do so much digitally. A picture's worth 1,000 words. And I could never be satisfied with anything I wrote, because it took too many words to describe, and you couldn't print enough pictures to show. But now with the digital format, you can show and tell with minimal words and with examples and pictures and video and pictures combined. So with your interest in the digital world, I would imagine that you can grasp and appreciate what I'm saying here. And that's where the education is going to develop.
A lot of the young kids ask, when they get into an implant system, there's a big variety of premium pricing implants north of $500, and then more value implants in the middle. And with over 400 dental implant companies to choose from, what advice would you give the young kids coming out?
I laugh, Howard, because the price of the cost that's involved is absurd. There is no reason, no basis for these massive costs that you just recited in some cases. The manufacture of implants, properly designed, is not complex, and it is not expensive, and there's no reason for it to be so expensive. You've got these you've got these hundreds of highly paid people, maybe it's in the thousands around the world, that are the salespeople and that create tremendous cost for the commercial end. But the actual cost of implant components and parts should not be great, and the cost has very little to do with the quality. The quality can be had inexpensively or expensively in the final sales price, but with the machining capabilities and with competent people that are designing, and there are many people that fit this bill, there's no reason for the cost to be the way they are. I hope and I expect to see the cost dramatically reduced in the coming years for the cost of components of implants. There's no justification for it. just like there's no justification for the cost of dental education today. I think it's a tragedy and a travesty to have students $300,000 and $400,000 in debt with a dental degree. When I entered my dental practice in U, we had no 800-pound gorilla on our back to pay for our education. And I fear that these great debts that students have will corrupt their morality of cost and fairness to patients. We all should treat every patient the way we would want to treat our brother, our mother, or our father, with care and competency and with fair expense. When you go and you have any service, you want to be treated fairly and you want to be treated competently and you want to be treated the way that I'm sure you have treated your patients in your lifetime. Am I right or wrong?
You're absolutely right. It's we certainly live in strange times with this amount of debt, and the schools they don't seem to be focused on cost containment. They just
It's become a business. It's been commercialized. It's been commercialized just like our field of implant dentistry has been commercialized. Some of the things that I see in dentistry should be treated as criminal assault, and that is a tragedy.
that is a strong words, criminal assault, on some of these diagnoses and treatment plans.
Some things, if I were called as an expert witness, some of the cases I have seen treated, and if I were called as an expert witness and I was asked a question, I would have to say I think it should be considered criminal assault. And that's about as strong as you can say.
What did these cases look like?
It has damaged the patient, and it's been done for money. I don't think I ought to go any further than I have right here.
Since you've lived and practiced in Alabama, Florida, now France, when you go around the world, there's such a huge variance of adoption rates of patients getting implants per 10,000 people, and the percent of dentists even placing implants. Why do you think there's such a wide variety of implant adoption?
Education. Lack of education. It should not be cost. The cost of implants should not be a limiting factor in their utilization. The thing is that we have large numbers of implants that are competently made. The vast majority are overpriced, but there are many good quality implants available. But we have so little education that the results that are being gotten frequently are far less than they could be or should be if we had quality education starting in the dental school. But to have quality education, what do you have to have first? You have to have teachers. You have to have instructors who are trained competently and know what they're doing. We don't need turfs, we need competency and experience and education. I'm older than you, and I've had very little benefit of education. It's largely been self-education. But today, that's not the way it needs to be. We need to offer quality education to these kids when they're juniors and seniors in dental school, and we need to introduce them into good principles of surgical asepsis and soft tissue management, implant placements, bone manipulation. Probably there's less than 1/10 of dental students in the world that are taught anything about bone manipulation. And bone manipulation, it is just absolutely fundamental to maximize the placement of implants. Any mature edentulous site that you have is going to be bone deficient because you lose bone from the buccal when you extract teeth, and it heals, typically in almost every case. So if you drill a hole in that bone, you're putting an implant not in the location that a root was in, but you're putting it in the wrong place and on a smaller size than the root. But bone is plastic. It's amazing the plasticity that's in alveolar bone, both mandible and maxilla. I didn't appreciate this until the last 25 years, but mandibular bone is as plastic as maxillary bone when you understand how to treat it. But to do this type of treatment, you've got to utilize conscious sedation. So conscious sedation should be a basic principle that's taught in dental schools, not only for implantology, but for restorative dentistry, for pediatric dentistry. I have been patients for dental treatment traditionally, and I've been patients with IV sedation. Have you ever had IV sedation, Howard?
I have.
All right. What kind of procedure did you have?
A kidney stone removed.
Okay, you've not had dental treatment.
No, not for dental treatment. I have 7 going on leaves.
I've had restorative dental treatment done with IV sedation. It's absolutely marvelous. There's no stretching of the mouth. It's like colonoscopy. They say roll over and you don't remember anything else until you say thank you as you're leaving.
You're right.
Have you had a colonoscopy?
You're right. I just reminded. I've had IV sedation twice then because I had a colonoscopy when I turned 50, and now I have to get one. I just turned 55, so I need to schedule. You just reminded me to schedule for my 5-year update colonoscopy. But when you talk
Well, I've had about 5 of them in my life, 5 or 6 now.
Well,
I had 2 without, and then I've had sedation for 4 of them. And oh my goodness, what a difference it is.
I
remember saying turn over and then thanking them as I leave. And your dental patients can be the same way. I have used sedation since 1957 in my dental experience. I started using promethazine, Demerol, and Nembutal, and when Valium was introduced, I immediately went into Valium, and so I just can't imagine practicing dentistry, not only implantology, but practicing dentistry without IV sedation. It's just a gift to mankind, but we got to train people, but it ought to be in basic dental education. Every dental student should be being trained, not only in implantology, but in basic IV sedation.
When you talk about bone manipulation, it seems that many kids think that that's not necessary because they're just going to get a surgical guide and they're just going to drill through a hole on a surgical guide. What is your view? Go ahead.
Well, I don't use surgical guides at all, Howard. That's backwards to me. In training that we do with our kids, or I say kids, we've had students as old as 69 that started our training program. What I want them to do is take mounted models, use radio-opaque teeth, and set the teeth exactly where the final restorative needs to be, with the same length as the crowns need to be, and then do scans. And almost all of the kids we have in now have access to CT scans. And once you get the scan and the radio-opaque teeth in the correct position, then you see exactly what the bone relationship is. You know whether you can, with bone manipulation, expand the bone for the implant to be exactly where the root was, or whether you need to increase vertical height and width. The most predictable way to do to recreate vertical width is with a vascularized osteotomy. If the bone is suitable, you move the bone to the correct height with an interpositional graft. It's much less risky than with an onlay bone graft, and you get a precise bone height. Then with bone manipulation, you create the width that you need. If that's not possible and it's vertical, then you have to do onlay. But the world, again, is backwards, in my opinion. 99 and 99% of the bone grafts that are done are crestal incisions. That's not the way they should be done. You should almost never have an incision on top of a bone graft. You make your incisions so that you keep your flaps completely vascularized, and you put your grafts into place, and then you bring the tissue over them and close them with remote incisions, and your flaps are completely vascularized. So this is what I'm talking about as being a different dimension from what is, but it's the way it can be and the way it should be.
What do you think of a lot of dentists when they bone graft, they're drawing blood and they're spitting blood? What do you think of these?
Oh, that's tremendously useful. We use PRF. It increases. I think it just increases results, and it's a very safe. It takes a little bit of equipment to do it and a little time, but I'm very, very favorable to the use of these additives that we use in conjunction with the grafts.
When you're diagnosing and treatment planning a missing maxillary first molar, what do you think the pros and cons are of a 3-unit bridge versus a sinus lift? Because in a 3-unit bridge, you're removing tooth structure, but in a sinus lift, you're invading the sinus.
The sinus augmentation is one of it's as safe when it's competently done as an interpositional graft. An onlay graft, it always has greater risk than either sinus or an interpositional graft. But if you have virgin teeth, then I think that a sinus augmentation or a sinus lift, where you just elevate the floor of the sinus some to deepen a socket, is the appropriate treatment. But if you have teeth that have been restored and are severely worn, I think a 3-unit bridge is the appropriate treatment. It's what I would do for myself or for you or for a member of my family. But if there were sound teeth, then I would definitely want to use an implant if possible.
What do you think of the American Academy of Implant Dentistry?
Well, I think that not joined it early in my career, but because I didn't know any better. But I think it's the leader in implant education, and I think it's going to be the organization. It's non-commercial, and it's a democratic organization, and it's my hope and prayer that it's going to be the leader. Of course, it's the sponsor of the American Board of Implantology, and I expect it to be the leader in developing the graduate education that we need and will see developed over the next 5 and 6 years. I have a very ambitious plan, and I hope that it or something like it comes about.
When we talk about implant education, in the United States, there's kind of a lot of turf between the oral surgeons versus the periodontists versus the general dentists. Do you think the AID will pull oral surgeons and periodontists in, or do you think those will remain kind of 3 different turfs?
Well, there are and always have been oral surgeons, periodontists, and prosthodontists in the American Academy of Implant Dentistry. I think that the specialty, as it will develop, will train people to be competent in all phases of implant dentistry. But don't and never would want to exclude an oral surgeon or a periodontist from being a part of implant dentistry. But the specialty of implant dentistry, there is no specialty training program in the world in any of the recognized specialties by the American Dental Association that trains a person competently in comprehensive implantology.
So what do you see as the most common mistakes today in implant dentistry?
Lack of education. The teachers are not teaching the right thing. So the challenge is to train teachers and develop the graduate programs. We've got to develop programs to teach them the young graduate, but we've also got to develop the programs to teach the practicing dentist, whether they be 30 or 40 or 50 or 60 years old. In our program in Puerto Rico, we've had people, the oldest one we've had, I think, is 69 when he started the program. And this year we have a gentleman whose daughter graduated from the program this past year, and the father is coming this year. Interestingly, the daughter finished, I think she finished dental school a year ago. No, 2 years ago. I think she came to us right out of dental school. She did 2 sinus augmentations during the course, and I think now she's probably done a total of either 5 or 6 sinus augmentations, and she's out of dental school just over 2 years. Now her father, who must be well into his 50s, he's enrolled and is going to be a part of the program this year. How many children have Howard?
What's that?
How many children do you have?
I have 4 boys, ages 22 to 28.
Do you have a dentist in the family?
I do not yet have a dentist in the family.
Well, I have 2, but one of mine is already retired. But
your dad was a dentist, and there's 11 dentists in your family?
My father was the first, and there have been 11 dentists in the family. I have a granddaughter who graduated a year ago, 2 years ago.
What school did she graduate from?
From Columbia in New York.
Nice.
And we have been spread out over a number of schools. My 2 kids went to Florida. I finished Emory. My father finished the precursor to Emory. My brother finished Emory. My brother's 2 sons went to Alabama. Some cousins to Emory. So we've been spread out.
Now, Emory was a private school, wasn't it?
It was private, yes. Mm-hmm.
Was it Jesuit?
No. It's a Methodist. It was a Methodist school.
A Methodist school. Interesting. Speaking of your father being a dentist, implant dentistry has lost a few legends lately. Leonard Linkow, Carl Misch, Pierre Brandmark. Your thoughts on those guys?
Well, of course, Carl was almost like a son to me. We were so close. Lenny, I've been a friend of for 45 years. P.I., I met and knew him. And I said when we were starting that I'm one of the I don't know the word I used, but one of the old ones left. I'm not of the oldest generation, but I'm just under the oldest generation, and there's almost none of that generation left. And there are a number of my generation that still are around.
Yeah, I just think of what you 4 people brought to implant dentistry, and it's mind-boggling. One of the problems with I want to get to why do dental implants fail? And we have a huge problem in the United States where there's studies showing that at 5 years out, 20% of the implants have PeriImplantitis. And it also seems like it's that we don't even have a consensus yet on a diagnosis and treatment plan of PeriImplantitis. Would you agree with that or not?
Well, I pretty well understand the cause, Howard. To start with, you're drilling into a deficient bone and leaving very thin walls at the time implants are placed, and only a small percentage of dentists understand how to handle soft tissue to create stable gingiva around every implant that's put in. Those two factors right there contribute to most of the PeriImplantitis that you have. If you have vital, stable bone around the implant and you have good, stable gingiva, so you have circular collagen fibers that create a tight cuff around the implant, then you reduce the microbial invasion into the sulcus, and that's the primary cause of the PeriImplantitis that you have. So with education, those things, most of those things will end.
Would you say that's more reasons not to use a surgical guide?
For me, I've never used them. I come at it from a totally different. I think all implant treatment should, for fixed bridge work, should be prosthetically planned. You should plan your prosthetics and then see whether it's possible to do the surgery to put the implants in the same relationships that the roots were in, and at the same height. So I want to build it from prosthetic downward, not from a surgical guide and then build the prosthetics wherever the implant is. I want to put the implant where the root was and put the bone where the normal alveolar bone was. And we do that with a combination of surgery, osteotomies, and bone grafts, but principally with bone manipulation. If bone height is there, only a small percentage of cases is it not possible to manipulate that bone and expand it so that you can have the root in the same location that have the implant in the same location that the root was in. It's a whole different dimension from what you've been exposed to, Howard.
Exactly. What would you do if a patient walked in today with PeriImplantitis? There's companies out there saying their laser works well with it. Others are saying flap it, open it up. How do you get your mind around diagnosing and treatment planning existing PeriImplantitis?
Well, you first want to understand what caused it, and usually it's a cause of inadequate stable tissue and poor bone on the buccal. And once you lose that bone, it's problematic. It's possible it can be restored, but you've got to have stable gingiva. And if you're going to restore bone, you got to have stable gingiva around the implant. Prevention is the best treatment. The problems that we see with PeriImplantitis they do exist, but they're such a minimal part of the problems we see because we try to create stable gingiva at the time that every implant is placed. How do you create stable gingiva? In the maxilla, you move tissue from the palate over at the time implants placed. In the mandible, you expand the gingiva that's there. If that's not adequate, you do a gingival graft at the time you put the implant in. How often is that being taught in the world? Either one of those. It's very, very little, but that's the way it should be done. And that's the way it will be done someday.
You brought to implantology in 1974 the sinus lift operation, the inferior alveolar nerve lateralization techniques. Now a lot of people are trying to avoid those techniques by going to shorter implants. What do you think of these shorter, fatter implants?
Well, I try to always maximize the use of available bone. And I think I'm not going to use a very short implant if I've got more bone. than that. And there are seldom situations that I'm not able to create more bone when it's not there. Uh, I did a nerve lateralization on my wife 3 days ago, or and I did one 30 years ago, right after we married, on one side, and I had to treat the other side 3 days ago. But when we finish, we'll be able to, in 3 months, we'll put implants of probably 17 millimeters in her mandible, and she still has the implants I placed 30 years ago after the nerve lateralization on her left side. And I hope she can have another 30 years. She's only 81 right now. But I hope she can have another 30 years on the right side.
That is the most romantic implant story I've ever heard. That's the Romeo and Juliet of dental implantology. That is an amazing story. When these children who just got out of school, they see these sinus lift courses, sinus augmentation. There's several different types of sinus lifts. Will you talk about sinus lifts for a while?
Well, a sinus lift, when I first had the idea of using the sinus to enhance the implant placement, the first procedures I did were from the crest, and I would curette. I was making the implants all the implants I used, I was making them myself, and I made them to fit the area of bone they were going into. And so in the posterior maxilla, I would curette the bone to the floor of the sinus, saving the bone, and then with a try-in that I would make just smaller than the implant, I would crack the floor of the sinus and elevate it and put the bone around that elevated floor and then put the implants in. That was in '74. That was part of the prelude to doing sinus augmentations with autogenous bone, extraoral autogenous bone from the ilium. And a year later, I began to do full making windows, first from the crest, the first few cases, and then from the lateral wall. And of course, to do these procedures, Howard, you've got to do them with a level of surgical asepsis similar to general surgery. And the general dental environment is not the environment you're going to do these procedures consistently well. So as our young dentists are not trained in surgical asepsis, so that's another of the great challenges. In fact, in the training that I do now, I teach the students that the two most challenging, most difficult things they've got to learn is competency in surgical asepsis, because it's a second language. Dental asepsis is the first language, and surgical asepsis is a completely different language. And bone manipulation is a skill and an art, and that takes time and effort to develop that skill and art. Everything else is pretty mechanical. If you have surgical asepsis, you use remote incisions, you understand how to manipulate tissue, you learn how to create stable tissue around your implants, and of course you have to have IV sedation with these things to do them comfortably for the patients, and to do them successfully and comfortably for the surgeon.
Are you using a lot of membranes?
You're talking to a pretty radical person here today.
It's an honor. It is an honor to talk to you. I can still remember meeting you in St. Petersburg, Florida, and I was starstruck then, and I'm still starstruck now. What about membranes? Are you using many membranes today?
Well, Howard, since I started doing bone grafting in 1970, I was using millipore filters then, and I've always used barriers. We use resolvable barriers today. Uh, we use a lot of alloderm. We use different other tissues. Use pericardium, collagen. In the different teaching environments I'm in, I use what they have available. But I have always used barriers, and we use PRF in conjunction with the barriers on most or many of the surgeries that we do. And I think it enhances our results. I haven't done comparative studies with it, but I feel strongly that it is a positive product. Not having my own practice and not being able to comparatively evaluate things, I have to make assumptions that I can't be certain that they're correct because I haven't been able to evaluate them. But I feel comfortable using the PRF. I think it's beneficial.
One dilemma dentists have around the world is the patient wants the implant immediately loaded. They want to come in, get an implant, leave with a tooth. And what are your thoughts about immediate load, when it's applicable, when it's not?
Well, there are many places that you can do that and do it very well, but that comes back to the experience and knowledge of knowing where it's appropriate to do that and where the success rate would be good, and in the absence of parafunctional habits of the patients. If you got a patient with parafunctional habits and you do most immediate implants and load them, you're going to probably overload the crestal bone because your crestal bone gets most of the load from the loading implants. But I'm so impressed with about the possibility and potentials of immediate placement and loading, but it's got to be very carefully done. I think the future for one-piece implants is tremendous in these cases, where they're indicating can be used, and the cost can be so much less than the cost with many of the things that are being used. So, but I'm very impressed with the potential on Threeunit. In the anterior mandible, my goodness, we put 23 millimeter implants in the anterior mandible and load them. I could do that every day. And there are a few patients where teeth have been extracted in the anterior mandible that you can't use 20 or 23 millimeter implants. And they are tremendously strong. And you use one-piece implants in those cases.
So a very successful Clear Choice has been very successful doing immediate placement of the all-on-4. How do you like the all-on-4 concept?
Well, I think Shankar Harris says that probably the best all-on-4 and none-on-3. I think for fixed restorations that you're putting any patient most patients at risk with 4 implants, when it's always possible to do more if you're going to do full arch restorative. Now, much of this is basically dentures screwed in on 4 implants. And that should be a very cost-effective type of treatment, but it's not a cost-effective type of treatment the way it's being delivered. And frequently these entail removal of a lot of bone, and For fixed restorations, that goes completely opposite to my view. I want the bone supporting the implant to be at the height of the original bone, and my whole goal is to try to create that for a patient.
Are you cementing implants or screwing them?
No, I cement implants.
And what are your thoughts on, and why is that? And what are your thoughts on that?
It's my goal when I place an implant for a patient, it's my goal for that implant to be there for the patient's lifetime. I have a number of patients that I still have contact with that have implants that I placed in function over 40 years ago. And that's what I would hope for every patient that I treat. Certainly, you have patients where you have unsuccessful outcomes, and I have patients with unsuccessful outcomes. But it's my expectation that any implant I place for a fixed restoration, it's my expectation that that implant has the potential to last for that patient's lifetime. And with that said, a cemented restoration has got a far less maintenance and far more predictability for long-term service than something that's screw retained. And it's also aesthetically more natural.
What are your thoughts on socket grafting?
Oh, I think socket grafting is a real benefit. I don't think it's an absolute requirement. When you understand bone manipulation, if I were in my practice, if a facial wall is there, I don't need to socket graft it because the time frame for one cycle of bone healing is somewhere between 16 and 22 weeks. If you place your implants between 8 and 12 weeks, you can place them without losing width, and you place them with bone manipulation. You place them and you don't have the need for socket grafting. Also, when you perfect your skills with bone manipulation, you can take the thin ridge and expand it outward. But that is after you've become competent, and that's quite an education. I have no complaint or hesitancy for the young dentists that I work with frequently doing socket grafting, but I think the learning to handle soft tissue so that you get uncomplicated healing on the socket grafting. In the maxilla, you can advance palatal tissue and get primary closure, and you can use barriers, resorbable barriers over the mandibular socket grafting that enhances the healing. But I wouldn't do much myself with socket grafting because it's an unnecessary expense for the patient in my hands. But I think it's very useful for the young dentist who is developing his skills and his learning.
Do you think any implants have gone extinct? I mean, you used to make your own implants. There's subperiosteals, blades. Would you deem any implant system extinct?
Oh, of course, yeah. The vitreous carbon implant system took the country by storm in 1970 and 71. It was a space-age material developed by NASA. It was university tested and promoted by USC. It was a total failure within 4 years. The aluminum oxide implants, the Kyocera implant from Japan, and the American polycrystalline aluminum oxide implants were beautiful implants, but they lasted about 5 years and were considered complete failures as systems. The blade implants, subperiosteals preceded all of them. That was the first modern successful implant done in 1942 with Gustav Dahl. He did it in Norway, but he was Swedish. And then in 1948, Aaron Gershkoff did the first subperiosteal in the United States, and they have been used since that time. There's very little usage of them today, but in an atrophic mandible, a properly done tripodal subperiosteal is still a very excellent device when it's done properly. The blade implants were the primary implants from about 1967 until perhaps 1984, 67, 87, for about 20 years. The root form implants are the principal implants today, but there still are people who successfully utilize the blade concept, but it would represent a very small percentage of the implants that are done.
Do you think we're around the corner to having custom implants instead of buying an implant that already exists, maybe taking an image and using CAD/CAM to reduce titanium or using the printer 3D printing technology? Do you see custom implants around the corner?
I don't see how the 3D printing is going to be utilized with the titanium implants. With the tremendous selection and sizes of the titanium root form implants that are available, it's pretty difficult to not have a choice of a suitable implant for any site or any location that you need to have one today. I can't see the printing. I can't see at this point how it would have a place with titanium, but I think there is and will be such an availability of efficient, well-made, economical titanium implants that there would hardly be a need for a custom-made, more expensive device.
What about cantilevers? What do you think of how cantilevers are used in implant dentistry today?
Well, anybody with long-term restorative experience knows that distal cantilevers are trouble spelled with a capital T, whether they're on implants, on a teeth. Now, I have seen cantilevered lateral incisors that have lasted many, many years with minimal damage, but I have seen few free and distal cantilevers in restorative treatment that has had long-term good success, either on implants or teeth. So, and it's possible, there's just no need to have to use cantilevers because you can create suitable sockets in bone in almost any location in the mouth for the reception of a titanium root form implant.
If someone asked you, what book could they read to learn about dental implantology?
Well, Howard, I don't think the book has been written yet the way that I think it should be. Today in the education, most of the maxi courses are principally didactic or principally lecture. What we need is clinical training. We need surgical training. I mentioned to you that I feel like I've been on a carousel all of my life. And to the point I am right now, I feel like I've essentially completed the carousel. And the concept that I have arrived at, I've given it a name, and it's NIRSAB, NIRSAB, which means natural implant restoration in stable alveolar bone. And that's what I and the ones that work with me tried to achieve. And uh, I mentioned, or I had thoughts when we were talking about the digital component of education, and I think that that's where my future lies in trying to impart and to teach this NIRSAB concept that I've arrived at, because digitally we can guide and direct surgically through surgical procedures with pictures and video that it's impossible to do in a textbook. And so, in the time I have left and the people working with me, what we hope to do is to digitally transmit the knowledge that we've learned and the techniques that we've learned into the students that we encounter and the students to follow. So that's where I think my future lies, is not in the hands-on teaching, because it's very limited the number of people you can reach. But digitally, if we can transmit the how-to accurately with the many different procedures, then that's what I hope we can accomplish.
That would be an amazing accomplishment. And when you do it digitally, you can scale out. You can teach so many people around the world at the same time.
Well, that opens you up to any that are interested. Now, in comprehensive implantology, if I speak to a group of 100 people, if I excite 2 or 3 or 4, that is about the most you can hope for, because you can awe a lot of people, but to excite people to want to do it or want to be part of it, that is a very, very small percentage of people. And but that's where the teachers will come from, and that's what I hope we can expand, is to reach more and more people, and to create a core of teachers that will be here to be the teachers and the instructors in the comprehensive education we're going to develop.
Well, you promised me an hour of your precious life, and you gave it to me, and it was just unbelievably amazing. Gosh, I just love this so much. Dentaltown now has 250,000 dentists around the world, and 60,000 of them downloaded the app on their iPhone. And we put up 400 hour-long digital courses, and they've been viewed almost 1 million times from every country and territory on earth. And it would just be the greatest honor ever if you have an hour digital course. I would love that. I'd love to put that on Dentaltown. I mean, you're a Hall of Famer, and if you ever have time to put up an hour course, it'd be beyond amazing.
Well, thank you, Howard, and I've enjoyed speaking with you tonight. I wish you could be in this beautiful country that I'm in right now.
Well, Ryan and I were in Paris last year. So, what's your favorite recommended French wine?
I have no taste for wine at all. We have a collection of, my wife's first husband was a connoisseur and a collector, and we have them from 1933 Chateau Yquems up through the Petros and Romani Contis, and yet neither she nor I have any taste for wine. So we sometimes serve wines to people who appreciate it, and we have a beautiful collection in the cellar, but I was reared in Alabama. The only wine I knew anything about was Blackberry Hill, and it cost 25 cents a quart. I never drank any of it, so I'm not one to talk about wines. But we have a beautiful wine cellar if you want to come look at it.
Okay, well, next time I am in Paris, I am definitely coming by your house.
All right, well, you have an invitation.
All right, well, that's an honor and a privilege I'll never forget. Thank you so much for coming on the show today, all the way from France, to talk to these dentists around the world today. It's been an honor and a pleasure.
All right, thank you very much, Howard.